Week 5 lab. This is our final system for labs. This is the urogenital system. So we're going to look at the kidneys, which we already talked about in lecture, and then the genital anatomy, the genital structures, which is really looking at the reproductive structures that we're now currently speaking about in lecture as well. Just a bit of a heads up before we get into the structures, we're going to be talking about structures such as the male genitalia, female genitalia. So just bear that in mind. I know this may be a bit of sensitive information for some of you. Please let me know if anything makes you uncomfortable, and we can certainly have a discussion around that. Okay, so let's go ahead and get into the structures here. And it's really nice that we already looked at the kidneys in terms of their function, in terms of their physiology, because we're going to have a really good backdrop to discuss the structures of the urinary system. So let's talk about where the kidneys are. Now, the kidneys are retroperitoneal organs. They're paired, meaning that we have two of them, and they sit pretty much behind all of the abdominal viscera and behind the peritoneal cavity. And we can kind of speak about some of the structures that cover the right and left kidneys, respectively, and the fact that the right kidney is slightly lower because of the large liver on the right side. So we have the right kidney a little bit lower. It's going to be covered by the hepatic flexure, so the ascending colon. If you remember this from the abdominal structures, the ascending colon takes a turn here, and that creates here we go. So the ascending colon right here takes this turn, and that creates the hepatic flexure or the right colic flexure, which sits right in front of the bulk of the right kidney. We also have the liver here. So a large part of the right lobe of the liver covering the right kidney as well. And then we can see parts of the duodenum. So here we can see the stomach. This is the stomach. A bit of the duodenum would be right about here. Let's use another color. Okay, here we go. So we got parts of the duodenum right here coming off of the stomach. And this is also covering pretty much the hilum of the right kidney as well. So structures covering the right kidney, the liver for the most part, also pushing it a little bit down further, lower in the abdominal cavity. We've got the hepatic or right colic flexure, and then the duodenum. Let's look at the structures covering the left kidney. So we've got the spleen here covering part of the left kidney. So this is the spleen. We've got the stomach as well, covering a big bulk of that left kidney. Here's the stomach. We can see the splenic flexure. So here again, we can see where the transverse colon takes a turn. The splenic flexure comes in contact with the left kidney, and then the jejunum. So remember we talked about the placement of the small intestines. The duodenum was kind of centrally located. The ileum was in the right lower corner, and the jejunum was way up here in the upper left corner. So the jejunum is going to kind of cover the left kidney as well. And this is how the kidneys kind of relate to some of the other abdominal organs that we talked about last week, being really the posterior most structure of the abdominal contents. So let's look at a single kidney. So this is one kidney. We know that it's coming in contact with the adrenal, but the adrenals sit or rest on top of the kidney. The kidneys are covered in a fibrous capsule, which is then surrounded by perinephric fat, which is also a protective measure for the kidneys. And then finally, that is covered by renal fascia. So a very thin layer of connective tissue that's encircling that perinephric fat. In terms of the medial indentation of the kidney, this is called a hilum. And this indentation is what gives the kidney this bean-like or kidney bean or a kidney-shaped appearance. It's also the area where the vessels, that is the renal artery and renal vein, are communicating into and out of the kidney, as well as the ureter. So here's where we have the ureter that's exiting and descending down towards the bladder. So the hilum of the kidney is this medial indentation that's really important for these structures that are entering and leaving the kidney on either side. Let's look at the internal anatomy of the kidney. Now, if you take a kidney and you cut it across, not across, but top to bottom, so a frontal section of the kidney, you would see these pyramidal structures that we call renal pyramids. These would be closer to the center of the kidney. You would also see a distinct difference in the way that the kidney appears, the color of the kidney. The outer part of the kidney, we've talked about this many times, would be a bit more pale. That is called the cortex, the renal cortex, whereas the inner or the deeper region of the kidney where we have those medulla is going to be a bit darker in the color, a bit deeper staining, and this is what we call the medulla. So the kidney has these two distinct regions, the outer cortex and the inner medulla. Now looking deeper into the medulla or the medullary structures, we have the renal pyramids, which are these pyramidal shaped structures. And we have the renal papilla. The renal papilla are the projections of the renal pyramids, right? If you think about this as a pyramid, the pointy or the pointy edge of the triangle or pointy edge of the pyramid is called the renal papilla. Papillae for several of these, and one would be a singular papilla. We also have the renal column. So these are the areas that are interspersed in between the renal pyramids where we don't have pyramids. These are the renal columns. And then as we get closer to the center of the kidney, closer to the hilum that is, we have the calyces. We've got the minor calyces, which are the smaller duct portions where we have the aggregates of the collecting ducts. If you remember the collecting ducts from our nephron structures, all of these are dumping into several calyces. So they start with smaller collections called minor calyces, and then they eventually kind of aggregate together to give us major calyces, which are closer to the ureter itself. And then that eventually leads into the ureter, which is found at the renal pelvis. So the renal pelvis is really this entire region that is somewhat synonymous with the hilum, right? It's going to be at the hilum, but it's going to be the drainage of the ductal structures that are leading out towards the ureter. Okay, and then also located at the hilum, we can see some nerves coming in here. We can see the renal vein and we can see the renal artery. Let's look at the blood flow and the division of arteries. So the major artery that's coming off of the abdominal aorta that supplies blood to the kidney is called the renal artery. The renal artery then divides or branches itself into several different branches that have different names as they get smaller and smaller and smaller. So the first branch is called the segmental arteries, and the segmental arteries divide in about 3 or 4 major segments, and they go to several pyramids at a time. The segmental arteries will then branch again and divide into the interlobar arteries, and the interlobar arteries are pretty much branching to the pyramids, as we can see here. That will then branch again to give us the arcuate arteries, and the arcuate arteries, as they are appropriately named, are kind of curving around the base of the renal pyramid. So we can see the arcuate arteries curving around the base or the largest part or the bottom of the renal pyramids. And then that branches into some very small arteries called the cortical radiate arteries. These are sometimes synonymous with the interlobular arteries. So not interlobar, but interlobular. And these are the smallest branches of the arterial supply that are really going towards the nephron. Now, this is going to start to get us into the afferent arteriole, then the glomerulus, then the efferent arterioles. So as we get beyond the cortical radiate arteries, we really get into the microcirculation. We really get into the smallest arteries that are leading us into the nephron circulation. Okay, so here again, we can see that. We can see that those cortical arteries will then branch into, again, those are sometimes called the interlobular. So that is synonymous. Interlobular is synonymous with the cortical radiate artery, which are the smallest branches of our arteries, our kidney arteries. That leads to the afferent arteriole, which leads into the glomerulus. Remember, the glomerulus is nothing but a ball of capillaries stuffed inside that glomerular capsule, which is the Bowman's capsule. And then from the glomerulus, we go to the efferent arterioles, which goes to the peritubular capillaries, structures we've talked about before, then to the vasa recta, coming in contact with the nephron, the loop of Henle, and then finally from the peritubular capillaries and the vasa recta, we then get into the venous structure, starting with the interlobular vein. So the interlobular vein is the smallest vein, and from here, just like what we saw with the arteries, we're going to get larger and larger and larger until we get all the way back to the largest vein, which is the renal vein. And this is pretty much where we start the blood flow from the kidneys back into the venous structures, heading back to the heart. So to remind ourselves the structure of the nephron here, we've got the proximal tubule, we've got the Bowman's capsule here, we've got the arteriole structure, so afferent arteriole, efferent arteriole, and then the glomerulus kind of stuffed inside that Bowman's capsule. We then have the loop of Henle and the distal tubule, and then the collecting ducts. The collecting ducts are draining towards the minor calyces, as I mentioned earlier. Now, I want to point out we have two different types of nephron depending on where they're located. We have cortical nephrons that are closer to the cortex, and their loops of Henle, although they dip down into the medulla, they don't go all the way down as the others do. The juxtamedullary nephrons, these have longer loops of Henle's that go right down towards the minor calyces and come all the way back up to the cortex. Okay, and we want to bear in mind the distinct regions here, the cortex being closer to the outer surface of the kidney and the medulla being closer to the center of the kidney, where we get into the pyramids and closer to the pelvis. Okay, let's continue to look at the blood flow from the kidney. So we mentioned that from the efferent arteriole, we go to the peritubular capillaries and then to the vasa recta, and then we get back to the interlobular vein, the smallest of the veins. And from the interlobular veins, we go to the arcuate veins, which again are veins that are curving around the base of the pyramids, very similar in their location to the arcuate arteries. Then from there we branch to the, or converge rather, to the interlobar veins, slightly bigger veins that are heading back towards the renal vein. And from there we get back into the renal vein. Okay, now some anatomy will tell you that the branching in between the renal vein and the interlobar vein are called segmental veins. That terminology, that branch, that distinction is not always there. Some anatomy will tell you that it goes right from the interlobar vein back to the renal vein and not necessarily following the path of the arteries. Okay, so just bear that, that distinction in mind. And then from the renal vein, we go back to the inferior vena cava, which goes all the way back up to the heart. All right, so that is the blood flow to the kidneys, the major internal anatomy of the kidneys, and some of the outer structure of the kidneys. Let's turn our attention now to the urinary bladder. So the urinary bladder is the second important structure of the urinary system. This is where urine is stored until the time of voiding. We're going to start by looking at the ligaments that kind of hold the bladder in place, that anchor the bladder in place. The first one is the median umbilical ligament. This is a centrally located ligament. It goes from the top of the bladder and extends out as an extension here, and then from the anterior and superior borders of the umbilical region, okay? So it's gonna kind of connect to the umbilicus region, which we call the belly button region in layman's language, and that is pretty much anchoring the bladder in its location, kind of in the suprapubic region. Other two ligaments that are helping to anchor the bladder are called the lateral umbilical ligaments. They're found on either side, and they help to extend the bladder to the lateral portions of the umbilical region, right? The lateral edges of the umbilical region. Okay, so together, these ligaments are helping to anchor the bladder to the suprapubic region, which is maintaining the bladder and umbilical connection. Let's talk about a few other structures. So let's remind ourselves first that the ureters, there are two of them that are coming from each of our kidneys, are connecting to the bladder at the inferior region. So the ureters, although we're not seeing the continuity of the ureter here, it's going to go all the way down kind of to the bottom, and it's going to empty into the bladder at the ureteral openings. So we have two ureteral openings on either side, closer to the base or the bottom of the bladder, that are bringing the urine that's coming from the kidneys into the bladder. We also have the detrusor muscle, which is the bulk of the bladder, the smooth muscle that makes up the entirety of the bladder. And then we have the trigone. So the trigone is this triangular shaped region that's bordered by the urethral orifice and both of the ureteral openings. And this creates this triangular shape of smooth muscle. Now, the clinical significance of the trigone is that this is the area that's really sensitive to stretch. So sensitive to whether the bladder is empty or full, and is going to send signals to the brain about voiding of the bladder. And we talked about the relative divisions of the autonomic nervous system that are governing the guarding reflex, which is keeping us from urinating, and then also governing the voiding reflex, which is allowing us to urinate when we so choose to do. So just to wrap up the structures here, we've got the detrusor, which is the smooth muscle of the bladder, the triangular shaped region of the bladder that's really sensitive to stretch called the trigone. That is bordered by the internal urethral orifice and the paired ureteral openings where the ureters communicate into the bladder. Let's talk about the sphincters. So we've got the internal urethral sphincter, voluntary, involuntary smooth muscle. We've got the external urethral sphincter, which is voluntary skeletal muscle. And we can see that the external sphincter kind of sits in the pelvic diaphragm or the floor of the pelvic wall, the pelvis. And it's skeletal muscle, meaning that we can control this when we're ready to void. And these are the two structures that are helping to keep the bladder, to regulate the bladder rather, or to regulate the flow of urine, depending on our somatic or voluntary decision to use the bathroom or decision to urinate, and the stretching of the bladder, which is governed by the autonomic nervous system and regions of the brain.